You know what they say on TV. Push one of Epi's stat.
Yeah, nobody actually says that.
Exactly. Welcome to the real world of nursing. I'm Millicent Olulade, better known as Nurse Millie.
And I'm Nurse Tara.
And we're surviving 12-hour shifts, nonstop call-lights, and pure hospital chaos.
And each other.
This is Shift Happens, where we talk about what really happens on and off the shift.
I'm Nurse Millie, and
I'm Nurse Tara.
And we are here for y'all to clock in with us and do a shift. Now, it's not going to be 12 hours, but we can at least get a good 30 minutes out of you, and then you can clock out and take a lunch. Today, we are going to be talking about if it isn't charted, it didn't happen. Okay, so we're going to start off with our chief complaint today. And the purpose of that is to introduce the topic, explain why it matters, and present the central question to the episode we will answer. So our chief complaint today is, I've spent more time charting than caring for my patients. So the reason we say that is because documentation is extremely important. It's an essential part of nursing, but many nurses feel like they're spending more time proving they provided care than actually providing it. Mm-hmm. So today's question is, has charting become more about protecting ourselves than caring for the patient? So, Tara, what do you think about that?
I hate that phrase, CYA, cover your ass. When referring to, make sure you chart it to CYA, cover your ass. I think it just should be documented just because it's so important to document. Because like you said, if you didn't chart it, it didn't happen. Mm-hmm. I'm really careful. I'll say, when I'm doing a prone case where the patient is on their stomach, maybe mm-hmm. for like a back case, mm-hmm. and I'm charting that, I've checked their eyes, because the number one complication for a prone patient is post-operative blindness. And one thing is they can have pressure on their eyes. So let's say they're prone and they had something on their eye that could cause blindness. Let's say they're under general anesthesia 4 or 5 hours for this procedure. They could wake up with blindness. That's never happened to me, thank God. But I'm so diligent about charting every 15 minutes that I'm checking their pressure in the eyes. I'm down there, under the drape checking. So I feel like it's very important to do that. I don't necessarily think, well, I'm doing it just in case I'm sued. I don't think that way. I just want to make sure that I'm just being documented, that I'm actually doing the task of checking. Okay. So I think we should just get away from charting just for what the lawyers would say. A lot of times that's it. It just is very important to document it and that way.
Well, I have several questions for you now that you've stimulated some thought for me. Number one, for those of you, not myself, but for those of you that are thinking about having 360 Lipo, and you're saying, we'll get back to the topic. Let me write down my notes. Okay. Because the girls want to know. I mean, I kind of do too. A friend told me to ask you right quick. She texted me real quick. So when you're doing 360 lipo and you're on your stomach to get the lipo in the front, and then how do they flip you over a dead weight when you're asleep? And then that's my first question. And then number two, what about aspiration? Mm-hmm. I mean, I never even thought about the eye pressure, but I initially think aspiration, even though you're supposed to be NPO at midnight. Mm-hmm. The other question I have is, how do you keep, if you're intubated, how do you keep that tube stable? So those are my three questions.
So you're never going to be at risk for aspiration if an endotracheal tube is present. Okay. So usually when you do a prone case, you start where they're supine, you put them to sleep, then you flip them like a pancake.
It takes everybody in the room to flip them?
It takes a few people.
Okay.
And so you just, of course, I just do with the head, lucky me. So I just take the head and turn. Okay. And there's a pillow, what's called a prone pillow. It looks like a square, and it has a cutout like for a face. Okay. And then the tube sticks out, and you just connect the circuit back to the endotracheal tube. Okay. And that's the only way I would feel comfortable putting someone to sleep if they're going to be prone. They would have to have an endotracheal tube in. Okay. Yeah, so you do that, and then take the fat out, and then put them prone, and put in the fat.
So usually it's low risk when you're switching from supine to prone.
Yeah.
Okay. I was wondering that.
Yeah, I feel like we do it a lot.
Oh, wow.
Yeah.
Okay, I was wondering about that. My second segment, back to the topic, is when you talk about charting. Okay, so I'm a newer nurse, but I know that we've been charting electronically. We have switched systems, throughout the past and present. But so I'm sure, actually, right before I came into nursing, when I was in nursing school, they had paper charting. And it was such a scramble for people to transfer from paper to electronic. So I feel like the electronic helped because you're not scouring through paperwork. But also I feel like because it's electronic, there's more boxes to check and more tasks to do. So what is your perspective from being a part of that transition from paper charting to electronic charting?
So I've been a nurse since 2001 and I remember paper charting and I feel like charting wasn't essential. We were just charting not as much.
Okay.
So I definitely feel like we're charting way more and checking way more boxes. And in nursing school, I don't know if you remember this, you were taught don't chart something in a million different places. I feel we do that now because
it's repetitive.
Chart it, so repetitive. And I just think that we were taught not to do that. So for me, the transition, I guess you just adapt, but it's just easier. Now I wouldn't ever want to go back to paper charting because the vitals shift over, everything you just click and it makes it a lot easier than paper charting. I wonder how we even did that because it's a lot of work to go and chart everything and write everything out now.
I think another positive thing about electronic charting is that you don't lose, it's not fragmented care. So if you're seeing one physician or you're at one facility and then you go to another, everything's on record. But I have noticed since we've had electronic charting, like if I go to my primary care physician or even when I was working in the hospital, you lose that contact.
Yes.
Okay. So I'm telling him about my problems and he's looking at me, but he's charting and And in primary care, obviously you have to see like a patient every 15 minutes. So I completely get it. I recognize it. But I would think for the non-healthcare patients, they'd be like, okay, what's up with this? And then the patient satisfaction scores would be like, oh, my physician wasn't listening or my nurse wasn't listening. They were just charting. And so I feel like that's like been a big thing.
Yeah, I agree with you with that. It just takes some of the
intimacy.
Yeah, and being so personal when you're just charting on your computer instead of looking at the patient. But you could just, I think some people do a good job of saying, I'm still listening. I just need to chart this in the computer, and patients know because they have my chart now where they can look up their own chart in the computer. I never set it up because I don't like technology sometimes. Next, shift report. The purpose of this is to explore the topic through personal stories, experiences, humor, and honest conversation. Millie, what's the most ridiculous thing you've ever been expected to chart?
I think how much poop a patient let out in a diaper. I'm like, are you wanting to know like the number of like about how much does that weigh? Oh. And I'm like, how am I supposed to? Sometimes I feel like people don't understand what they're asking, like to make sure their bowels are good. I'm not really sure. So that definitely was a weird one for me. Tell me about the funniest charting mistake that you've ever seen or made.
I think every nurse everywhere knows this one. And I just love it so much because we always talk about it when someone's like, oh, that's pussy.
What?
They'll say, oh, it's pussy. And you shouldn't say pussy because I think I maybe would spell it P-U-S-Y, but most people spell P-U-S-S-Y.
I would have spelled it that way. Okay.
So it's pussy. It's purulent. That's the proper.
Can you explain to the audience for those non-healthcare providers what purulent means?
Well, it's pussy. 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 Purulent. It's the white.
Yeah.
Yeah.
Right. Same thing.
Yeah, gross. So I feel like that's one that if you see that, it chuckles. Or a charting mistake. There's a lot of, they have those things, a bunch of charting mistakes. Now I don't see it as much because we're not writing.
Yeah, you just click on a button,
We're just
a little box.
clicking, and then even assessment, they tell you everything like you're assessing. When I say the eyes, I'm checking the eyes. I don't really do like a narrative anymore where there's a bunch of charting. But I feel like that's the most I think everyone is going to agree, like that's the number one. But Millie, tell us about a time when charting kept you at work long after your shift ended. Oh gosh.
That's all the time.
That's what I'm saying.
Because
right?
Again, we are, trying to perform the duties of taking care of the patient. And sometimes you get so caught into that, or you have so many things to do: draw blood, do consents, get patient from surgery and back to surgery, charting that, charting this. And then you have to empty drains, monitor this, look at the chest tube. You obviously can't take a lunch because you don't want to get behind on charting. But then there would be times where I'd stay an hour and a half after work because I have to catch up on charting.
Yeah.
Which, if you have difficult patients, you have a lot of discharges, and with discharges come admissions. And so, I would say at least a fourth of my shifts that I would do, I had to stay after to chart.
Yeah.
And
this was you working on the floor.
This is working on the floor, definitely. Or now let's talk about this with electronic charting. When the power goes out or the program goes down, and you get stuck with a stack of papers.
Oh, yeah.
Oh, and then an hour before it's time for you to go, all the computers come back on. So now you have to put all the information that you've been paper charting in
when you have downtime.
7 in the morning.
Oh, gosh.
To put it back in the computer.
Yeah.
So you're scrambling. It's so inconvenient.
Yeah.
So I'd always think, I get the whole paper charting thing, but it is a lot of paperwork and things can get lost or put in somebody else's chart. But also, you cannot fully rely on computers, on AI, and on electronic devices or programs.
Right. I know in the operating room, if we do like a quick case, the nurses are like, I didn't chart anything because it's so fast and they're running around getting things for everyone in the room and helping get the patient on the bed and put to sleep because they assist me with that. They're like, I have no time for charting. So they've done nothing because the case was so fast. So I know that for them can be really frustrating.
And then you have to remember everything that you did.
Yes.
But if you do it enough, you can.
Yeah.
But if you have a high load of patients and high acuity, then you're like, okay, now what happened with this? What happened with that? Okay. What do you think could be one thing you could permanently eliminate in charting requirements tomorrow?
If I could.
Hold on, that didn't make sense. Richard, can you scratch that? If you could permanently eliminate one charting requirement, let's not say tomorrow. Okay. If you could permanently eliminate one charting requirement, what would that be?
I already know what that would be because this is so annoying.
Okay.
At one facility I work, we have to chart separately the Propofol, the patient's name and how much we gave and wasted. That is so dumb because Propofol is not a narcotic. It's not required. I don't know why this facility makes us do this, but it's so annoying. And it takes time to me away from the patient because I have to chart the Propofol.
As you're giving it?
Well, after I get, like I put their name and I'll say how much I gave. And I've already put in the chart how much I gave. And it has to match up. I don't know. Yeah.
Do you think it has something to do with people stealing it? Like they want to make sure the amount you discard matches the amount?
Who's stealing it?
Girl, I don't know. You know, people, I don't want to name names, but people take Propofol to go to sleep.
Well, it is. Right. I gave you the thriller dose, not the killer.
Exactly. So I don't know. I'm just thinking outside the box.
Well, I'm sick of charting it. It's not necessary. This is the only place I charted. Now, fentanyl, Dilaudid, ephedrine, I understand all that.
Right.
But why am I charting Propofol? I don't know.
Maybe we can ask chat.
So, Millie, what's something nurses do every shift that never gets documented, but takes a tremendous amount of time?
I think the emotional support, because patients come into the hospital or any facility scared with a lot of questions. Then you have family members to address. And then it's like the physician comes in and explains everything to them. And then as soon as they leave, they're calling you like, hey, what does this mean? What does that mean? I remember, bathing the patient, cleaning them, sitting there, taking the time to do that, or just explaining whatever questions they have or talking them off a ledge.
Right.
Like, also, my husband will come home and be like, I'm so talked out. He's like, 50% of my job today was meetings or seeing patients, doing orders. But a lot of it was counseling, whether it be my colleagues, whether it be a patient, whether it be a patient's family, whether, especially in adult or geriatric care, a lot of DNRs when it's time to have that conversation about end of life. And so some families just aren't ready to, accept the position that their family member may be in. So that takes a lot of time. And then once you've done all that counseling and you go home, then you get a call from the facility that's like, hey, more family members showed up and they want to know. So we're having like a sibling rivalry or, opposition about what should be done with their parent.
Well, can I answer that question?
Yes, you may, please.
So I think that something that I do, the patient's like, will you pray with me? Oh. Will you give me a hug? I'm not going to chart pray with the patient or I gave them the hug. Sometimes they just like, will you hug me? Or will you hold my hand? I feel like that's something I do a lot of times during my shift, but it's not documented. But if they are really stressed, I do give that verse in.
Honey, if you put me to sleep, I want you to pray and hold me too.
Yes, I'm giving you a little margarita.
Okay. Tara, what's your favorite charting shortcut or documentation tip?
My favorite documentation tip.
Because you can't be taking no shortcuts.
No, I don't take any shortcuts.
That was to catch you up.
But my documentation tip is just really what we've been pushed and just be in us. If it is not documented, it didn't happen. So anything that I do that I feel like special thing I did, maybe not pray or give someone a hug. But if the doctor tells me to do something, I always make sure that per surgeon that I charted that.
Or patient refusal.
Yeah, patient refusal.
Non-compliance.
I guess I cover myself, but not really cover myself. But just it's important to chart those things. So that's always my documentation. I just feel like that's really important. Like, how do you know you did it if it's not documented? And even to pass on the patient, how do you know if it's nowhere? If the patient got antibiotics. It's assumed that I gave the antibiotics because we have to give everyone antibiotics. But if it's not charted, then it's not done. So it's really important to do that.
A little side note, how do you know if there's too much charting versus just a traditional chart? Because I feel like there was this nurse that I worked with, and you know how you have the boxes you can check for your assessment? In the addendum box or comments box, she would write everything out. Patient was ambulatory. Patient came in. Respirations were this. Respirations that. Patient as this. Patient was laid down at this time. Patient took this. Patient was put to sleep. And it was excessive. And she's like, you know what? If you read my stuff, it's a narration. And I'm like,
I think that's too much.
It was a lot.
What do they say? KISS. Keep it simple, stupid. I'm not calling her stupid or you stupid, but sometimes just keeping it simple and charting the facts are more important than charting a whole bunch of mumbo jumbo.
Okay, I agree. So we're going to head over to the nurse's station. It's time to take a break. I need some water and I got to get some charting done. But while we're doing that, the purpose of the nurse's station is to engage the audience through anonymous admissions, listener questions, scenarios, and advice. So again, guys, if you want us to answer some of your anonymous questions or you just want to share a comment with us or something you'd like us to address, please DM us or leave in the comments at Shift Happens Podcast on Instagram, YouTube, or Facebook. And also you can follow us on Spotify, Apple Podcast, and TikTok. So our anonymous admission for today is sometimes I don't chart something until an hour later because I was too busy actually taking care of my patient. What do you think?
That's important. You should not take care of your patient to document something. It's like, oh, you're coding a code blue or the hard. Well, let me chart that real fast. That's why I feel like on the electronic charting, I think one, you can mark an event. So you can just hit it real fast, click, and you can proceed to take care of the patient. So that's another good tip. And sometimes you just have to chart an hour later. I think that's appropriate because patient care is key. That's essential. It should not trump taking care of documentation to take care of the patient.
So let me ask you this. I'm going to piggyback. I like a piggyback off the anonymous question. How do you find the balance between charting and taking care of a patient? Because what if you're like a new nurse or it's a very critical patient and you're not going to be remembering everything to chart it later because you've been doing so much intense care?
I would write things down. I would just write myself a little note because I always keep little notes, and I would just write myself a little note as you just remember what to chart. Now I just chart a few things as I'm taking care of the patient, and I get everything done, and then I go back to charting just to get it done quickly. But as you do it more, you get a lot faster in your charting.
I think that's an excellent tip. Our listener question is, what's one charting habit, shortcut, or tip that have saved your sanity?
I said that about marking the event. Or taking notes. What do you think?
That's a tough one. Because I just feel like charting is just all over the place. That has saved my sanity. I also think just not getting overwhelmed in the moment and just saying like, hey, this will get done. And you know what? Some days I just have to come to terms with the fact that I'll be staying late. And that's okay because I'm still getting paid. Right. So just not getting overwhelmed by having to mark everything down. It's almost so for the newbies, it's like when you're in nursing school. For me, I wanted to read all the chapters. And then once I was done, I didn't retain any information. So I would talk to my professors about it. And they're like, you cannot remember everything. What are the big takeaway points here? And I'm like, everything is a takeaway point.
Yeah.
And so you just have to train yourself to just say, hey, I can't remember it all. I can't do it all, but I'll do my best. And
speaking of takeaway points, let's go to our diagnosis.
Okay.
The purpose of that is to answer the chief complaint by sharing the biggest truth or takeaway from the discussion.
So we've allowed documentation to become the measure of nursing when it should simply be the record of nursing.
Charting isn't the enemy. Unsafe workloads are.
Yeah, we definitely
that's
addressed
the key
that.
thing.
Yeah. So let's talk about our treatment plan of the day. So the purpose of our treatment plan is to leave listeners with practical advice, encouragement, or actionable steps. So I feel like document accurately and objectively, but never lose sight of the person behind the chart.
Find documentation habits that work for you. Ask for help and remember efficiency comes with experience.
And we said touched on that. Yeah. Perfect. So our discharge instructions are going to be, you want to end with one memorable message listeners should carry with them and take home.
If listeners only remember one thing, the best nursing care doesn't happen on a computer screen. It happens at the bedside. Your chart should tell that story, not become the story.
I feel like we've done a pretty good job addressing all of these points. So if you guys remember in nursing school, we had our clinical pearls. So the purpose of that is to finish with a brief educational tip, a nursing concept, or a medical takeaway. So charting by exception. Can you define that for me?
Yeah, a documentation method where only abnormal findings or significant changes are recorded according to facility policy. Okay. That's a good one.
So basically that means focus on what is different or clinically important rather than documenting every normal finding when your facility permits it, like within normal limits.
Like that one chick.
Yes.
She was charting too much.
It's too much.
Kiss.
Again, guys, thank you for tuning in to Shift Happens. We hope you enjoyed our episode. It's time to clock out now. However, if you would like to leave us some anonymous admissions or anything you'd like us to address, please do so in our TikTok DMs or comment area, Facebook, Instagram, or if you're shy and you want to hide in the nurses station, you can go ahead and listen or watch us on YouTube, Apple Podcast, or Spotify. Thank you guys for tuning in.
Thank you.
I'm Nurse Millie.
And I'm Nurse Tara. I need to go finish some charting.
Yeah, we have charting to do because it matters so much.
All right, that's our time. The charge nurse is already looking for us. Thanks for working with us.
And if you enjoyed the episode, make sure to hit subscribe on Apple, Spotify, or wherever you listen.
And follow us at Shift Happens on Instagram, TikTok, Facebook, so you don't miss the chaos. I'm Nurse Millie.
And I'm Nurse Tara.
Please don't hit the call button. We are clocked out.